Toe charity, which is CPFT's NHS charity.
So I'm Louise Bullivant, I'm the Voluntary Services Manager at CPFT.
My name is Mary Spencer and I'm a butterfly volunteer.
I'm Helen Gould, I'm the butterfly coordinator.
So we wanted to come and tell you today about the butterfly service. We are just over a year now in terms of service, and we wanted to give you all an update of the incredible things that Mary and her team of volunteers are doing, led by Helen. So just to give you some background and context, this is a collaboration between Head to Toe and CPFT Voluntary Services, something we were talking about for a very long time, and in the end of 2023, we managed to get £150,000 funding from the ICS Healthier Futures Fund to actually be able to fund the service and provide funding for Helen's role to take it and deliver it going forwards. So there was a lot of work that we did kind of in the interim in terms of developing the service. We host a steering group that is across the system with some partners, which I'm sure Louise will tell you about in a second. And we did a lot of scoping and co-production work. We work specifically with the Anne Robson Trust, who are a training provider for end-of-life butterfly services that run across the country. And they've been really great in terms of helping us, delivering training, supporting Helen. And this is the first service of its kind that delivers volunteer community compassion respite services in the community. I say respite, it's very much bedside companionship. It's about giving soul carers a break when they're looking after somebody at the end of their lives. It's also about providing companionship for people that are on that journey too.
Thanks. So as Hannah said, the funding, the work between the voluntary services and Hannah and the team at Head to Toe, it's quite a long process, but obviously one that was fulfilling because we got the funding. So following the funding, we did do a bit of a sort of identifying the problem and the reason for sort of, why we got to the point where we wanted to apply for the funding was conversations that myself and other colleagues had with the district nursing team to think about how could we develop sort of opportunities to support our community, and looking at one of the catchphrases that actually Helen has put together for the service is making every moment matter. So people are at end of life, and we wanted to put something in that was community based, and as it says there, it's the first of its kind, but also making every moment matter. So there was a lot of research and scoping exercise that happened to develop, or look at the needs. So we had to see what was happening out there across the community sector, what volunteering was happening already, Sue Ryder, Arthur Rank, North West Anglia, the colleagues across the NHS, and how could we potentially put something in place where there were potentially gaps. So that's what we did. We created sort of a possible solution, looking at wonderful butterflies that Mary's going to tell you about all about her story and what she's been doing and the difference that she makes. And I think the only other real thing I wanted to add to what Hannah said is I'm so impressed by the co-production, not just the co-production from a system, but also the co-production with involvement from our volunteers and our patients. And hopefully from the stories that you hear, you'll really get to understand what a difference that people have made, but also the opportunity they have to develop and sort of grow the service and make it a really good, unique service. So over to Helen for the delivery.
So I came into post in October last year, and that most of the back work had been done, but then we decided we needed to look at the standard operating procedure, we needed to look at recruitment, we needed to look at the volunteer role, and we needed to then network across and decide. We started with Boroughbury Medical Centre, which I have worked closely with to receive referrals. And then really my job's been since then recruiting, getting referrals in, matching patients. The next slide was it.
We lost the slide. I don't know who is driving the slides.
The next one, please. Oh, keep going. That's it. So the service update, that's where we're at the moment. We went live in December. We received our first referral in January. We have 84 hours of service user contact, which is absolutely amazing. We've done 48 visits There are more visits today, there are more visits tomorrow, I think we only have Mondays where there aren't visits now, which is fantastic. Received 18 referrals. We're actively supporting 8 individuals and their families. I've got 11 butterflies in post, and one of the things that we're working really hard to do at the moment is recruit. I run a bespoke training day, which Rachel comes along to welcome volunteers on. And we cover communication. They meet some of the professionals involved in end of life. It's a good opportunity to meet other butterflies. We cover, because it's so bespoke, and we know that some of the situations the butterflies may come across, they need to know what equipment they may see in the home. They need to know what to expect. They need to know emergency contacts, because they're not medical, they're not clinical, but they are facing people who are very, very poorly. So it's making sure they're aware of their own safety, how to look after themselves and the community as well, and what they can and can't do. So it's very unique to the service. We've trained them in hand massage as well, which is really lovely. So we have a colleague who will come along and train all our volunteers in hand massage. So that's really nice too. And we've got some butterfly volunteers in the recruitment stage. So what happens is we receive the referrals, and you'll see on the next slide where we receive our referrals from. So this is our partnership working. What happens is we receive referrals from all over the services, some from CPFT, the district nurses, some from the specialist teams. We receive some from Burberry, but we are now branching out to all PCNs in Peterborough. We're working really closely with Thorpe Hall. So Thorpe Hall don't have any community butterflies. They are using our service to then support their patients too. So we will often get a referral from Thorpe Hall, a discharged patient who lives alone and is isolated. I will then match them with a butterfly volunteer and we'll go and support them. And also MWAF, so working with the palliative nursing team, they will also refer in for a butterfly volunteer. So that's our collaborative partnership working instead of reinventing the wheel. So not everyone having their own butterfly service. What happens is the referral comes to me. I will then look at my pool of volunteers. I will then match a volunteer to a patient. We will go out together to meet that patient for the first time. And then it really is off to the volunteer, as long as they're both happy. I talk to the patient and the volunteer separately after that meet to make sure that they are happy with that match. And then they then agree a date and a time, and off they go. They check in with me before and after every visit to make sure they're okay and how was the visit, have you got any concerns? And then I review the service at 4 weeks to make sure both the volunteer and the patient are happy, get some feedback, which you'll see, and then off they go. So over to you, Mary.
Oh,
Thank you. Thank you for coming along.
hello everybody, it's quite exciting to be here. A little bit about my background. So I was employed in 2011 by CPFT as a newly qualified OT. I went into a non-traditional role in the dementia care training team, which I was in for the best part of 9 years. And then after that, I went into one of the neighbourhood teams as a community occupational therapist, where I was until 2024. During that time, I supported both of my parents who passed away. In 2014, my father had an acute episode of heart failure, and he was admitted into Hinchinbrook Hospital. Unfortunately, I was told that we couldn't get him back home in time, they didn't think, and so he was very scared about being in hospital, and he made myself and my sister promise that he wouldn't be left alone. So we made that promise, and each of us spent the next 10 days, night and day, one of us was with him the whole time, supporting him. In March of last year, my mother, who was then in her 90s, was becoming more frail. There wasn't anything particularly wrong with her, she was just getting old. And then she said to me, I don't feel as I want to eat anymore. And so I was getting the idea that we were probably into the last months of her life. So I applied to take a year out from work, which I'm pleased to say it was agreed that I could do that. I stayed with my mum, and she passed away in May. But during that time, because I had the moving and handling skills and because I knew the system, I was able to keep her at home in her own bed. She died in her own bed with the window open, the sunlight coming in and hearing the birds outside. She didn't have any other professional carers come in. The only people that came in to see her were the district nurses to administer a bit of end-of-life medication. And that was a much better death. If you're going to have a good death, that was the way to do it. I'd learned a lot from the situation with my dad. Not that anybody in Hinchinbrook Hospital, they were all lovely, but you know, the whole environment was completely different for her. So that's my background in that. I very strongly feel that if we can give people the best few months of their life at the end of life, and if they can stay at home, if that's where they want to be, we should be able to do that for them. So one kind of after my mum passed away, I had time to think about, you know, what am I going to do? Am I going to go back to work? What would I like to do moving forward? I decided actually that I quite like to retire. But I was still looking on the CPFT jobs pages, and I saw Helen's job come up. I didn't particularly want Helen's job, but I did like the idea of what was being arranged. And so I quite often email and sort of said, oh, what's going on? You know, I'd be quite interested in this. And I got something back saying, well, we're not quite ready to go yet, but we'll put your name on the list. And so they got back to me when they were ready to go. And I went through the recruitment process. So I had my mini interview, went through all the, you know, all the paperwork, as it were, yes. So once we got through that hurdle, then I attended some of the training sessions, which were lovely. I felt during those training sessions, I felt very well supported. I threw in a very big question about moving and handling and helping people get to go to the toilet, because although the people we visit, you know, will get a letter saying that there won't be any moving and handling. I said, do they understand that means that if they ask me to help them get to the toilet, I can't actually help them to do that? So there was a big conversation about that, wasn't there? But on my first visit, Helen did bring this up with a couple of concerns, so they're quite clear on that matter. And I thought it was very good matching. I got on quite well. I suppose with the background that I had in OT, I'd done an awful lot of reminiscing, having worked with dementia patients over a long period of time. So I was able to draw out a bit about this gentleman's past, what he was interested in, and so forth. And I felt quite relaxed with him from the beginning. And I think they probably did with me. Would you say so? Yeah.
They are, just to give you a bit of background, it's a couple who have a very active, or did have a very active, full-on life, and because of his aging and he's now elderly and frail, they are unable to go out, and they're unable to maintain these community networking that they had before. So they are very isolated. He'd had a spell in hospital. He'd come out, his health is deteriorating. She is, although she wouldn't say, she is now his carer. She doesn't class herself as a carer, does she?
No, I would. She would. She predominantly say that she was his wife, but that's her primary role. Yeah. But having done this reminiscing with him, I found out he was quite interested in aircraft, which is something my own father had been interested in. I have stacks of books at home that I couldn't better chuck out, so I brought some of those to him, and he's very interested. He's now ploughing his way through some aircraft books when I'm not there. He was very interested in drawing, so I said, oh, I'd really be interested to see some of these drawings. So he sat and showed those to me and talked about them. And he's also interested in board games and playing cards. So we've done quite a bit of that. And his wife often comes in and says, I notice you're still gambling. But yes, those are the sort of activities that we have been doing in the last few weeks. This has enabled his wife on on, I think 3 occasions actually, she's gone out. A couple of times she went out to the opticians, I think, and then she needed to go to a shop to return some things. I think she feels, now she knows me, she feels quite happy to leave him with me. And she said that when she came back the other week, he said, "Oh, you weren't gone very long." So she said, "I took that to be a good sign that the 2 hours had passed without him noticing." I think other ways I've been able to help are in helping them to navigate the NHS system a little bit. He has like one morning a week, he has an event he can go out to, and guess what? The COVID nurses were going to come and visit him on just that one morning. So I said, well, and she said he's much better after he comes back from this visit. So I said, well, surely we can change that. And she said, oh, I've tried ringing up and I can't get an answer. And, you know, and she's an elderly person. She feels as though she's letting the NHS down if she doesn't let us know. So I had a chat with Helen and got their permission. And Helen just sent an email saying, actually, we won't be in that particular morning, and got it rearranged. And she was just so grateful. She said, I'm so pleased I mentioned this to you so that we could get it rearranged. Also, his rising recliner stopped working, so I gave them some pointers about where they could go to try and get that sorted out. It's just generally just trying to ease things and point things out to them, because I currently know the system quite well, but maybe that will date over time. But
so just on that point, Mary, without raising concern. So because I call the volunteers call me before they go in for safety, they call me when they leave. We have a debrief. If there are any concerns regarding health, safety, anything like the COVID jab, we've also volunteers, because they are going every week regularly, they are noticing deterioration in patients and changing. They then raise that with me. It's not their job to follow. I know they could end up spending hours trying to contact a health professional. So they raise it with me. It's then my job to then contact either specialist nurse, GP's practice. It depends on the concern. I will then raise that with the relevant health professional. We are now looking into statistics and data around, can we avoid hospital admissions by doing this? The volunteers are there every week, they're a constant, they are raising their concerns. We raised concerns that a lady had deteriorated, which obviously in the nature of their illness is likely. She had a chest infection, she couldn't find the GP's number, but the volunteer assisted her to ring the GP herself and get that appointment. Would that have been an hospital admission? We don't know. So we're now looking at the probability of the concern, whether it would have led to a hospital admission or a jet call out or an ambulance call out. So that's something we're looking at the moment. Sorry, Mary.
So what else I would like to say is that, you know, I've felt during the process of becoming a volunteer, I felt very well supported by Helen and Louisa. You know, having the training days, being able to talk about our concerns quite openly. They're always there to ring if we need anything or if we're concerned about anything. And I've had a couple of conversations with Helen about this because I supported carers in a previous role, and I know that it makes an immense difference if you feel that you're supported, because you feel as though you can give better to your person if you're being well supported yourself. So I'd like to thank Helen and Louisa for their help in that. And how do I feel about things now? I feel as though I'm really helping someone, and that gives me a great deal of pleasure to make somebody's life a bit fulfilling in the last few months. He did say to me, he said, in fact, the other day he took my hand and he said, "Thank you so much for coming." And he said, I feel a bit more alive. And he said, and you made me think about things that I haven't thought about for a very long time, he said. So I do feel as though I'm making a difference, both to him and to his wife. So I think it's a very worthwhile scheme, and it would be lovely to see it expanded if that can happen.
And this is the gentleman that Mary supports. support. So with his permission, I went out and talked to the family on Friday, and they gave me the photo to put on. So that's their feedback for you to read. You want me to read it? Is it easier if I read it for everybody? Otherwise, you.
Why don't you read it out, then we'll
Yeah,
have to
that's
move
fine.
to close.
So Mary has been here asking me questions about my life. We've been talking about the garden. She's been very interested and made me a cup of tea and biscuits. Mary's pleasant and understanding. The conversation has been testing my memory. I can't always remember who and what, but talking to Mary has helped me put things in order. I enjoy the reaction from the other person. Sometimes it takes me time to have a flowing conversation, which talking is helping. And his wife, Elizabeth, said, for me, it's knowing someone is there, that I am able to go out knowing Mary is there with John, and I worry less. Yeah. So this, honestly, the volunteers are the most amazing bunch of people that I have. I couldn't be more proud of. They really are special, very special people. And some apprehension, understandably, even ones with experience come into the service thinking, oh, I'm not sure I can do that. And for me, the priority is retention. Definitely retention of these amazing volunteers, supporting them. We haven't had a death yet, so we don't, but we are supported by other services to support our volunteers. And like I say, I talk to them at every visit to make sure that they're okay. These people are giving up their time to support our patients, and it's important we look after them. So thank you for having me along.
Mary, that's an incredibly powerful articulation of all the amazing things you've been doing. So big thank you to you for that, and lovely to see that you're still part of the CPFT family. Be great, I imagine you would say, to get more volunteers.
Yes, please.
Yeah.
If you know anybody who would like to volunteer, that would be amazing. Yeah.
And just to be clear, they don't have to have a healthcare background.
No. So our volunteers come from all backgrounds and all experiences, and it's really important that we, Louisa and I, if they come along and have a chat with us and the butterfly service isn't for them, then we will signpost them into another volunteer role in CPFT. But yeah, they can have informal discussions with us. I go out and I support them well. If it isn't for them, that's absolutely fine. But yeah, no medical backgrounds necessary. No.
There's lots of lovely comments in the chat as well. So thank you. We would love to hear about how the service expands. Thank you to all four of you. To Hannah in particular, who put in the original work to get the money in to help make this possible.
Try and get some more.
Yeah,
We are trying.
there is nothing probably more important you can do than to make somebody feel listened to and cared for as they near the end of life. Nobody should be alone in such a situation. So huge thank you to you for the time you've given us this morning and for the work that you're doing. So we will let you escape. I'm trying to hide it in this tiny room. Thanks, Helen. Thank you so soon. Right, again, so very welcome to everybody who's on screen with us today. A number of our governors with us, which is brilliant. Cree, who is one of our NEDs, is joining us remotely today due to other constraints. So I think now we will say farewell after that really, really impressive presentation and move into the main body of the meeting. So in terms of apologies for absence, I have received apologies from one of our NEDs, Jackie McGetty, who is unwell today, unfortunately. I haven't been notified by the Ed. Oh, and Ed Bullmore, yes. And Ed, as of Saturday, will cease, as we have said previously, to be an Ed. So we'll thank him for one final time. Any declarations of interest? Any new ones discovered since we have last met? No. All right. In which case, let's go to the minutes of the last meeting. We'll go through them before accuracy in the first instance on page 1, 2.
Sorry, Chair, please, on page 1, Steve Cox, I think it's, Steve is registered as non-voting, but Steve, you are voting.
Yes.
It's just an amendment for detail, Chair.
Page 2, we've done. Page 3, page 4, 5, 6, 7, 8, 9, 10, it was a long meeting, 11, 12, 13, 14. Any matters arising from those minutes that aren't going to be covered elsewhere? In which case we will say a very big thank you and those signed off for the record of the meeting. And then we go to the action log, where there is one action open, which really revolves around the assurance framework. And here we are awaiting publication of the new NHS plan. I think it's still scheduled for
You like, Chair.
indeed. All right. Everything else closed as far as I can see, which is great. I haven't been notified of any other business, but none has been discovered by board members since then, so that's fabulous. And just to note, as usual, we will take questions at the end, time permitting. If anybody's got any questions as we go along, if you want to put them in the chat, then one of the corporate governance team will pick them up. We'll make sure that we get answers to you. I'm going to invite you to take my chair's report as written and read. I wanted to draw out a couple of things. The first is that we clearly live in interesting times in the NHS at the moment. To talk about it as a service that is feeling stretched, I think is probably accurate. It's a service that awaits a 10-year plan, but we're not waiting for the plan. We know that it will emphasise all that we hold dear, which is serving our communities and people ever better within resources which are not infinite. And difficult decisions will have to be made. That's true of every single NHS trust in the country. Anybody who's working in health is wrestling with how do we deliver better care, but within the confines of the budget that's available to us. And that is our job. So nobody is seeking to say that it's an inappropriate challenge. It's simply what we're here to do. But what I did want to just mention, because I think it's so important, at times such as this in public services, there is a danger of forgetting that everybody who works in the organisation will touch in some way what good care looks like for the people that we serve. Sometimes roles are described as clinical, non-clinical and support. And I would say that's not always helpful or not necessarily recognising the value that resides in the work that people do, like booking appointments, making sure that IT works, making sure that we can have the processes that allow us to employ people safely and securely and get them paid. All of these are essential areas of work that enable us to be the organisation that we need to be and that people expect from us. So my plea is, whilst recognising that we have to do difficult things, it's for everybody who is interested in CPFT and indeed any NHS trust to recognise that value resides everywhere in terms of the contribution that people make. And then the second thing I would draw out, talking about the value and the contribution that people make, is to my left, is Nikki. Nikki has been our interim trust secretary for a few months now, and she will very soon be returning to her 2-day jobs, moving from having 3 jobs that she is doing for us. Nikki, I think I would want on behalf of all of the board to say the most enormous thank you to you for all that you've done, all that you have brought to the board in supporting all of us. We couldn't let your final meeting go unnoticed. You were back again to present. But Nikki, a huge thank you from all of us. You've been absolutely outstanding. I don't want to delay any further, so as I say, I will leave the rest of my report as written and move then to the Chief Executive report.
Thank you, Chair. Good morning, everybody. Hello, people online. Just a couple of points. I think I'll follow the Chair's lead here and say the report is to be taken as read unless there's any questions. There are 2 points I'd like to raise. I think the first is a significant thank you to our workforce at this point. Times are very unsettling in the NHS. There's a lot of narrative and discussion around changes, leadership changes, infrastructure changes, and we as a trust are not immune in that. Ourselves as an organisation have also been asked to participate in national instruction, which we are working through as both a board and an executive team. But we've been briefing our workforce as often as possible, but with a real sense of how we get through this next bit together is really important. And so it was a significant thank you to all of our which are continuing to do all of those amazing things that they do in despite of those potential changes around them. But please, for all of our workforce listening to this call or any call that we make, we are trying our uttermost best to try and navigate this bit with as minimal change as possible. That said, I think the last briefing, Chair, that myself and the executive went on with the teams, of which we had 350 odd members of staff join us and several hundred more that will view this over a period of time, is one message I wanted to give out to the organisation was that now, even though things are fluid, even though things are changing, now is definitely not the time to take our eye off getting the basics right. Getting the basics right are keeping us safe, they're keeping us caring, they are most definitely helping us to respond when we need to, making us effective, and most importantly, giving us the opportunity to demonstrate that we're well led. That is not a link back to the CQC, but it is their framework against their 8 domains, which obviously we take very seriously. But we need to make references here that getting the basics right keep people safe, and that is so important as we move through this. And getting the basics right is not all about some of the fancy glowing stuff. You just heard an amazing presentation of people doing what you think are the basics, making someone a cup of tea, sitting, talking to somebody about their garden. That is not overly difficult in terms of complicated and scientific and all of those things, but it is straight from the heart. And if we carry on doing that, we carry on getting it right, then we'll be the organisation that we want to be. And I think that's something that I am really keen to make sure that we continue on. The final thing on my report, Chair, I'd like to say is I am very much looking forward to a meeting we have invited the Chair and Chief Executive of the Race and Health Observatory to come to CPFT and talk to us about our commitment to tackling and managing diversity in our workforce and our workplace. This is something we take very seriously, something personally I take very seriously. And I think this organisation has been through some of its challenges, as have many more, in regards to respecting and representing that diversity wherever it can. And so talking to the Chair and Chief Executive about us being a vanguard in this space and leading out with them as a Race and Health Observatory, I was delighted when they said yes. So they will be attending the board in the short term future to come and talk to us about what those opportunities will look like. And you'll see a lot of schemes that we have deployed around the organisation, whether they be reverse mentoring, whether they be diversity schemes, whether they be employment opportunities and so on and so on. All of that will then come around some of our what's called our PCREF offer when we start to link into how our board leads on diversity across our whole organisation. And Chair, I'll take the rest of the report as read and happy to leave it there.
Thank you. If I could, one thing I should have mentioned when I was doing my update was about our governor elections. Nominations closed last week, and I'm delighted that we've had a really good response to people putting themselves forward to become governors. So my thanks to existing governors, many of whom are here joining us this morning, for all the hard work that went into trying to encourage people to take up these really important roles in terms of making sure that communities and those we serve are
of everything that we do. So hugely encouraging to see that. All right, then we will move to the board assurance framework. Thank you.
And thank you, Chair. So colleagues, you'll note from the board assurance framework that there is a change and reduction in the current risk score under objective 1, and this is around our relationships with our key partners. I think it's safe to say that this is an evidence-based reduction on both our interactions and our role in the system, albeit those systems may change in terms of the new architecture as the ICSs start to develop. This was predominantly started in terms of a seed change last year, and I have to turn to the Chief Operating Officer here with a significant sense of thanks for leaning in heavily over winter with OPAC and our other teams, because that was directly referenced by our partners, both in our acute and commissioning arenas, on the basis that we did support a significant amount of people not needing a referral into the ED or not referring straight into secondary care, but being supported closer in their homes and in the communities. Subsequently, since then, we've continued to lead with our partners on shaping some of the changes locally, one of which is what's called the big moves that the ICB has demonstrating. So if colleagues want to reference back to that, then please, the ICB have published that within their board papers. We can share that too, but those big moves are principally around to do with urgent and emergency care, to do with planned care, to do with community care, and then to do with commissioning. And as we start to walk across those 4 areas, some of those areas that we indeed have been asked to take a lead on through the Director of HR and Strategy is on the development of neighbourhoods, the development of place, the redesign of community, and the redesign of mental health and learning disability services, which is to make a modern, more fit for purpose set of specifications which have needed to have been reviewed for some time now. So this is a really good opportunity and a sense of confidence from the ICB leading into the trust to ask us to lead on this, which both I'm grateful for, but represents a change in perhaps the relationships of old. So this is a really good sign for us as we move forward collectively as a system. We will, of course, work with our ICB irrespective of its shape and design as that starts to resettle by the end of this month. And we will reconstitute any relationships, partnerships with our providers if we are in a bigger pool of which we are currently working through with our ICB. Provider relationships are really good. In fact, some strategic roundtables have been started already. One of those which I'm grateful to NWAF colleagues, to Hannah Coffey and the team, to visiting us to talk about where we can work collectively in partnership. Some of that revolves around some of our interface from an acute and community perspective, some of that research and education. And I don't want to make a small drum roll about our new status, but we can pick that up under any other business if that's okay. But that's one good example of how we can support from a research perspective. We have strategic roundtables also being set up with Papworth, CUH, University of Cambridge, and Anglian Ruskin University, and also perhaps slightly surprising when you talk about the statutory partners, but with our non-statutory partners of voluntary sector agents too, including Mind, Rethink, and some of our significant voluntary agencies. So I'm really looking forward to next year as we move into a redesigned partnership. As I say, Chair, there's a lot of change around us, but we shouldn't take our eye off what's important. This is a good example of working collectively together to do that.
Any questions?
Thank you. So I've got one question and just a comment. So really great to see the updates. On research and innovation, which is heading in the right direction as well, which is great to see. And there's still the question of an R&D base in Peterborough. I just wonder if there's any more we can do collectively with partners to help us find that base. And then the comment is just on the revenue resources, to note that we've got the trust efficiency report now up and running, which is reporting into BNP, which I think gives another level of assurance in terms of the progress being made there.
Yeah, thank you, Steve. So I'm very conscious this is a public board, so I'm going to have to be somewhat sensitive about what I say next. But our recent notification of being awarded a university teaching department status, the University Teaching Hospital, with the University of Cambridge really solidifies that research agenda to a point where there are only a small number of people in our sector that have been able to achieve that. We have also opened those conversations directly with ARU with a sense of working with them strategically. They've asked me whether I will lean in to help them from a strategy point of view, which is a contribution to their strategy, which should be with another set of partners. One of those areas is to look at establishing much more research in the Peterborough area, because we need to make sure that research is available to everybody who works in an organisation, not just what you class as an atypical member of staff, and I don't mean that to be rude. Normally they are reserved for particular people at a particular point in their careers. So what I'm really keen to see is that research is available for nursing, allied health professionals, social work, and our medics, and a conversation with Judge Business School for those that wanted to go into non-clinical research and look at additional opportunities there. That conversation with ARU is progressing, so I'll be able to bring that forward. With regards to the trust efficiency programme, I think this is really important for us as a trust. Last year we were, Kish will talk about the end of year report, but last year there was a lot of heavy lifting required towards the end of the year. This time what we wanted to do, and we promised the board, is that we would do the heavy lifting at the start of the year to do the planning, so that we can provide that appropriate assurance through the committees, through into BNP, this is performance, to give you a sense of where we're heading. And most importantly, I think, Steve, what that needs to be connected to is that quality impact and EDI assessment that comes with that, to say that whatever we're doing, whatever changes we're needing to make, they are for the right reasons and they will be not dilutive of care. In fact, they should be enhancing of care. And that will be run through formal committees to the board and then run into our board when it's appropriate.
Kathy.
Yes, I just wanted to add something else about R&D, which is we have recently established our own CPFT independent R&D office. So previously we were part of CUH, we had a joint office. I think this reflects the maturity of R&D in the organisation and is a really good opportunity to profile R&D much more strongly throughout the trust.
Okay. And it's worth noting that we promote research and innovation, not because it sits in isolation, but because it helps us deliver better care. That's what it's all about. Mike.
Steve, thank you very much. Could I ask you or Kathy what progress has been made with regards to developing a clinical strategy, which I know we've talked about, and I'm hoping we're not waiting for the NHS strategy, but I just wondered if you could just give a brief.
Well, if I do a very small intro and then hand over to the Chief Medical Officer, I gate crashed the meeting, is what happened, and I saw an engine room that terrified me, Mike. So I left the room very quickly on the basis of the fact that there's a lot of progress. If I can hand over to Kathy just to talk about sort of the component parts of this and what the timescale is, please.
Yeah, so we have started the work at pace. Our very competent consultant in public health is taking a major leadership role in that. But all parts of the medical directorate are very active, and we've now spread that out to a much broader group, including the nursing directorate, and Holly Sutherland was there as our coup at the last meeting we had. We had a half-day focus meeting just looking at progress to date. We're planning to deliver the strategy in September. It's quite a lot of work, so what we've done is initial scoping, identified key priority areas, and we'll be going out to the organisation and trying to be very efficient by utilising existing meetings rather than setting up independent focus groups, because people can get quite exhausted with repeated focus groups. Yeah, we're very confident we'll be there by September.
A follow-up question, if I may, not necessarily for nonce now, but a patient and carer input into that critical strategy is included.
That's planned, yeah.
Yes, okay, thank you.
And Mike, if I may, that will loop back through Q&S committee so that you will have a sight of that as that routes through our governance structure. I am also, just to give the board assurance, I was very impressed to hear from our clinical execs around the table the wish and will to underpin this with an economic assessment that went around underneath it from an economic evaluation of what the input is, rather than this being the next 10 years. We need to also lock this into our delivery of our core strategy as a trust. I was very impressed to see that.
And also our social responsibility. So the plan to trying for more health status.
Right. Thank you very much.
That's brilliant. I might indulge myself by do another part of the meeting, but I'll do it here because it's strategic aim to people at the heart of everything we do. I know that in some parts of the country, retention rates are improving, particularly for nursing. I'm just looking to see whether we are seeing some green shoots, people not being quite as mobile as perhaps they once were.
So we have seen certainly the vacancy rates come down. And when we were doing some work with CQC and post CQC, our clinical vacancies were around 16-17%, they're down 11%. And we are seeing in some areas a reduction in our turnover. I think it's fair to say, Eileen, it's very service specific actually. So you still see some turnover in some of the sort of inpatient areas, but again, you've seen a sort of a reduction. What we can do, and something we should perhaps pick up in the People and Culture Committee, is a bit more detailed, deep dive in some of that. We are looking at retention and the retention support programme that's in the paper as well. And it's a decision that needs to go to People and Culture whether we continue in that programme given the costs associated with that as well.
I could say something on medical agency as well, which we are making some progress on that. So we've got clear plans for every single post. We've also, for the difficult to recruit posts, gone out to international recruitment, which is something we haven't done previously. And we're also in the process of joining the GMC sponsorship scheme, which takes about a year to get that up and running, but we've initiated that. So there is evidence that we're actually making progress now on some of the medical staffing issues.
All right, that's good to know. And as you say, we'll reverse back into this a little later in the meeting. Everybody content we move along? All right, in which case then, Mike, we'll come to quality and safety. I think this committee is to be renamed, isn't it? We wanted to get patient experience in vital.
Yes, so it is a bit of a mouthful, but I think it's important to get the balance right between quality. Well, the components of quality and safety include patient and care experience. So QS and QE might be the abbreviation that we will use going forward, because all three aspects of work need to be given appropriate attention.
You want to talk us through then, Mike?
Yeah, so I'll bring out, so this was a report following the meeting that we held on the 23rd of April this year. And I'll just bring out some of the points. The first is that other committees will mention this, but there are 6 new risks on the risk register, of which 2 relate to quality and safety, which issues with the estate on the Fulbourn site, and also our business continuity plans affecting potentially the way in which clinicians, nurses and others might have to move from online to manual records and the impact that has on their daily work and the safety of the care they provide. ECT provision in the south of the county remains unresolved, but we've reduced the risk because the chief manager is working with others to work out a solution to re-provide ECT in the south of the county. And I'm assured that patients who need it get it, but they have to go to Peterborough at the moment. From an operational point of view, just a couple of things. I think out of area placements, we're assured that appropriate out of area treatments remain under control, but inappropriate out of area treatments have gone up. So these are patients who we would want to manage in the county, but can't because we haven't got the facilities to do so. And I know that thinking is being undertaken to work out how we could re-provide and repatriate those patients over time. So that's one important area. The other is waiting lists, which we take very seriously. We've got very significant waiting lists in certain areas, particularly ADHD and autism and PSOT, which is yeah, that's it. And so we're thinking about how those services are commissioned and provided. We're thinking about how we prioritise people on the waiting list and reduce harm. And we're looking at the way in which the clinical model of care is provided, which might address these issues as well. So there are a number of pieces of work pointing at that. So at every meeting, we look at the safety and quality issues. We wait too long because it has consequences, particularly at this well, for everybody, but particularly children. And the third thing about operational is it was good to see that the financial efficiencies and SIP program that we're looking at, quality impact assessments are now being undertaken, and we're getting sight of those. So whilst the operational performance and the money is important, we are absolutely clear that we need to understand what the quality and safety impacts of those programs are. I'm pleased to say that the annual statement on mixed sex accommodation, there were no breaches last year. As you know, this committee looks at both mental health and community health, physical health issues. So we were pleased to hear about improvements in wound care and pressure ulcer management. Complaint response times, if I may, they remain too long, largely due to the fact that we need to quality assure the responses that go to complainants, but I'll let perhaps Chief Nurse Rachel pick that up. And we're also looking at the physical health metrics and monitoring of patients who receive rapid tranquilization on the wards to make sure that these patients are being appropriately managed. The data raises a concern. However, there have been no incidents reported. We received the annual quality account for last year, and the quality priorities for next year have been set, and they're set out in the Chief Nurse's report. We also looked at the patient safety incident response framework and plan, and you can see that there are three priorities set out there for the coming year with regards to patient safety incident investigations. What else? Compliance report, we look at not just CQC reports and inquiries, but also Mental Health Act visits, trust inspections, improvement plans and internal compliance monitoring. And that committee reports to us on a regular basis. We await, though, with interest of the CQC well-led review that was done in earlier this year. We had a very helpful and presentation on assertive outreach, which is a model of care which reaches out to patients who need a more purposeful and assertive approach. That service has an approach has been made, and working with the ICB to develop an assertive outreach service in this area, which was previously tried and is no longer. In terms of patient care and experience, as I say, we've talked about complaints which response times remain above target. Perhaps the only other thing is that what our patient and carer team do feeds in very importantly to the patient carer race equality framework. That's sort of a mouthful, but this is looking at the equality of access and treatment and care to patients from different ethnic groups, PCREFT, and the triangle of care, which brings together service users, patients, carers, and staff, is working well, and that will feed into our understanding of how these patients experience care and then what we can do about it, particularly where there's an inequity in terms of experience of care by race. I hope that's not too long, but that's some of the key points that emerged from our meeting in April.
Super helpful. Any questions? Oh, sorry, Kish.
You're looking at the screen.
Go ahead, and if you can project so that people who can hear you.
Yeah. So Mike, it's good to hear. I mean, you're doing the bit on variation. There's a lot on the agenda there, and in many ways you're capturing that, okay, by referencing things like differences in provision between Peterborough and Leicester. I think it might be something to consider for the future about variation internally provided services as well, okay, and about how that gets on the agenda, as opposed to just the place provision. Okay. There's one more fundamental as well. It ties in with the organisation's financial plan, really. The out of area treatments and the repatriation and seeing some timelines and actions, okay, will be really helpful, okay, to get coming through to the committee.
So I agree with both of those. And I think the first step for me will be having data on internal variation in care. Because at the moment that data is not seen, and understanding that will be very helpful, and equally timelines on the way in which we're going to think about repatriation of inappropriate out of area treatments will be important. I think that will sit between myself and Steve Cox, who chairs the Business and Performance Committee, because we're looking at it from a safety and quality point of view, which will operationally and financially will be implications too. So I think that's a kind of joint effort. Thank you, Kish.
Right. I know we can't go into detail today. It's good to hear, Kathy, that you are working on something to do with ECT on the south. Perennial issue here.
Yes.
How, in what sort of time frame do you think?
So we've set up an ECT and neuromodulation group. Also, the ops director in OPAC is doing some of the on-ground work in terms of rescoping what the options may be. And I see Holly has her hand up because she's been thinking in with the.
Yeah, so I had a really positive meeting with Papua at the beginning of this week around facility to provide ECT. So I'm just waiting to hear from their coup, but it was very supportive, actually very interested in our challenges and the fact that we have such an inequity. And we're keen to think about how they might support us with a physical space.
That would be brilliant. My cream cakes for Royal Papua, if they were able to help.
They provide Danish pastries.
Oh,
It's very nice.
okay. Well, we'd have to trump the Danish person. The other thing I was going, it's not in the paper, but I don't want to lose sight of it. I have an obsession, as some of you will know, about the absence of inpatient beds for female psychiatric intensive care in Cambridgeshire, the whole county, Cambridgeshire and Peterborough. If you're a woman, you go out of the county. That is one of the biggest inequities, I think, that we preside over. I'm not expecting an answer today. I don't want that to get lost anywhere.
I think that speaks to what Kish was saying and timelines around repatriating.
Just think we should talk publicly and encourage people to talk publicly about the fact that this is bane on decision making historically, shall we say. But thank you, Mike.
Thank you.
Everybody okay? All right. So Rachel, we are with you.
Thank you, Chair. As always, take the report as read. As Mike has raised the issue of complaints again, so I will continue to explain in terms of what we're doing. Obviously, the data in the report is February and March data. I can update board in that the improvements that we've made for since April. We've analysed the data. We're actually looking at a 25% improvement on the average number of days to complete a complex complaint, and a 22% improvement on the average number of days for a simple complaint. So just to recap on those actions that have been taken in the short term, we've done some process mapping and looked at the bottlenecks that have been identified in terms of the quality checking. We have removed 2 parts of that quality checking process, and I've taken on the role of final sign off, releasing that from the chief executive. Alongside that, I'd like to say the next steps is to continue to review the impact of these changes, and obviously, as I've described, that's positive thus far. We need to maintain that. I'd also like to say a thank you to the clinical directorates who've also been working really hard within their own areas to ensure compliance with the timescales as well. So all in all, I think there's a number of different areas that we're looking at to improve this. We are also looking at the thresholds and potential recategorisation of simple complaints to complex complaints. The reason for that being this was a decision 2 or 3 years ago. In actual fact, from my experience of now signing them all off, very few are simple complaints. A majority are complex. So we're actually confusing the situation. If you look at the improvement scores, they're very similar. I think we can streamline that even further. So I'm certainly wanting to ensure that the improvements, I think, will come through to the board, certainly from in June, July statistics will be showing this improvement. And obviously, this will go back through Quality, Safety and Patient Experience Committee. I'd also just like to raise in terms of sexual safety, sexual safety training compliance, where that continues to be marginally low of target. We have a newly appointed mental health trainer who commenced in post in April. Then their induction is now complete, and the number of sessions for training have now been increased. So again, we'll see a better performance from that perspective. And then lastly, in terms of what was in terms of advising the board that the inpatient trust falls rate showing positive SPC assurance against trust target. However, that has raised the issue in terms of the blood pressure, and there's a deep dive happening within OTAC Directorate. Currently, the issue being that if you go a minute over the 48 hours, it's not counted. So we're looking at that. That nevertheless, that needs to improve, and that's being looked at in detail.
Thank you. That's really, really helpful update. I think just want to reiterate the loop back on complaints back into the exec responsible for quality and safety. And the reason for using that reference there is that complaints obviously sometimes can be an interaction between an individual and the service, but there's always lessons learned within there. So one of the things that we wanted to make sure is that we weren't just responding to complainants. What we were doing was trying to address the concerns raised, but then unpacking that to see whether there would be improvements that could be made. So the thematic review of those complaints obviously running through Policy and Safety Committee, and that will also include a lot of the constituency concerns that are raised through MPs, because they loop back as well. Some of those are slightly out of context because they're in the community, but we have to make sure that we loop that back also so that they're all in one place now. I'm really pleased to see that. Thank you.
Any questions for Rachel?
I just want one point, which I didn't make in my report, which is you've got the 5 quality priorities for this year, which will feed into next year's annual quality report. And for me, what's assuring is that all of those priorities are linked to quality improvement plans, which are the way in which we will see these priorities progressed, put in place. So I was pleased to see that the plans now or around now, end of April, and we'll be following those plans through quality and safety as well.
Okay, that's super. If I could just say on complaint, and you're quite right, really important to learn from them. I think, Rachel, what would be great for you to take back through Mike's Quality and Safety and Patient Experience Committee, and then ultimately this board, is a sense not just a response to issues in terms of timeliness, but we would like some assurance that it's a sustainable proposition in terms of meeting reasonable expectations that people should get a response and that we're acting upon it. So if we can make sure that that issue, not just of fixing the problem, but then sustaining that position, I think we'd all get much greater assurance from that.
Yes.
Super. Stephen.
Thanks very much, Chair. Just under patient safety, Rachel, it's really positive to see reduction in tranquilization, the reduction in other sort of issues there. One thing I think we may want to pick up in people and culture is just the staff support that we put in post-incident.
Yes.
So maybe that's something we can pick up in P&C and just think about doing a bit more of a deep dive around that as well.
We have started and looking at that. It's the actual recording of it. They are happening, they're not being recorded appropriately. So there's an action plan, improvement plan for the director.
Okay, And can I just remind colleagues that although we live in the world of acronyms, not everybody on the call does. So BNP, PNC, QNS, they're engraved on our hearts. Just remember to talk about what it actually is, what it does. Rachel, thank you. And good to hear that crossover between the People and Culture Committee and Equality and Safety, particularly around the support for staff post-incident, which is just so important, both in terms of learning and support. Can I then go to Pri, who I think is on the call? Pri?
Hi, yes. I'm having some Teams issues, so I'll keep my camera off, which seems to make it better. I will, first of all, take the report on the People and Culture Committee as read. Our meeting was held on the 15th of May. There were a couple of things we needed to note from that committee meeting. The first of which was there was a slight delay and a challenge with mental health law training. That has now been resolved, and I think mitigations have been put in place as well. So we're expecting that not to be a risk in future. And I think just following on from a point Mike made as well, with business continuity, there is clearly an impact on IT if there are issues, but we did discuss within the People and Culture Committee the impact on staff as well and the additional burden it would place on them, and just something to be aware of, I think. A couple of things I just wanted to highlight from the report. The vacancy control panel is continuing to operate, and I think especially given the additional challenges of resourcing at the moment and the potential changes in headcount, it is important. We have noted that there's still a focus on clinical roles, but I think just to reiterate a point Eileen made at the start, the trust operates because we have lots of people in support roles as well, which in most cases are equally important. So I think whilst it's understandable that we're working that way with the vacancy control panel, we did just want to recognise that. We have discussed on a number of occasions appraisals. There are two elements to this for us as a committee. One is the fact that the completion rates go up and continue to increase to where they need to be, but also that staff within the trust are having genuinely engaging discussions about their development, about what they want, about how it feels to work at the trust. So we'll keep shining a light on that. There is a piece of work to be done about the high number of HR cases that are ongoing, in particular relating to sickness. So we will have additional reporting coming back to the committee on that. We also discussed the reverse mentoring programme. The feedback has been very good, and I know the team were keen to encourage senior members of the trust and the board to be involved if they haven't already been. We spent some time discussing the EDI strategy, the Equality, Diversity and Inclusion strategy, and it is incredibly important. And I think there were, again, two aspects to this. One is the link to the trust strategy and make sure that it makes sense and it works. But also, I think to find that way that all staff understand that they're part of the culture of inclusion. So how every line manager, how every employee operates and works and performs their role helps to build up the culture and the inclusive, the environment that we want to create. Just a couple more points. Shaping Our Future Together has come out with some really positive outputs, and we're just now starting to see the impact and feedback as that starts to be rolled out and delivered across the trust, although a lot of good work has already happened. We did discuss freedom to speak up. There was quite an increase in referrals, and in many ways that could be seen as a positive, that people are still continuing and are happy to speak up about their issues and the challenges. But clearly we will continue to monitor that as a committee. And finally, just to say thank you for the consultant job planning work that's been done. A lot of effort's gone into getting us back to the targets we needed to be. And then the final point I wanted to make was about the staff survey results, some of which results we acknowledge were positive and some acknowledge some challenges. I think as a committee what we wanted to see was a real focus on a couple of key areas. There will always be work to do, and I think that needs to be linked with the output from the pulse surveys as well. And I know the trust has also launched or launching an app that people can use to also input about their feelings and their thoughts. And I'll stop there.
Thank you, Pri. I'm going to bring in Kathy.
Yeah, I just wanted to mention a metric around consultant job planning. So we are only one of 2 trusts, mental health and community trust nationally, to have met the 95% target. So a good turnaround.
No, fantastic. And to come back to my question of sustainability.
Yeah, we've got plans in place so that this will never be a challenge again. We do though, there's something called level 3 and level 4. Level 3 is service level, and level 4 is actually organisational level. So level 4 is something which the NHSE have been aiming for, which is that the board has oversight of all e-job plans for all the workforce, not just medics.
Sounds like good ambition to have.
Yeah.
Other questions or thoughts? Kish and Steve. Kish,
No, please, Kish.
I think your hand went up marginally sooner.
Might be a relatively simple point. So I know there's some information in here in terms of bank and agency, okay, that you're monitoring at the committee. And I could see some references in terms of the sickness comments as well. Just wondering, do you monitor the numbers of long-term bookings that we have versus the short-term bookings?
Okay.
Yes, but can I pass that to Stephen?
Yeah, Kish, I mean, that's the next paper that I'll come to in a moment. But basically, at the board subcommittee level, we don't bring that level of detail up there. We could do, but that's monitored within the directorates themselves. Up with, that's one of the targets that we'll have for next year. Worth just thinking about. Yeah.
I'm going to Steve and then Man.
Thanks, Chair. I think it's worth just pausing on the achievement there in terms of what Kathy's just talked about, because there's only 2 trusts in the country. And I think it's a sentiment to, if we remember, if we just go before Christmas, we talked about 3 things as a trust. We talked about a 6-month recovery position, then a 2-year delivery plan, and then a 5-year strategy. It was really important that we were able to put down some quite heavy foundations whilst we were in our recovery phase in 6 months, which, if just indulging myself, there were 47 of those actions, all of which were complete within that 6-month period. This was one of them. And I think it's really important that as we form our strategy for the 2-year delivery plan, strategies move from being sort of passive to adaptive to responsive to then proactive. I'm really pleased to see a lot of the strategies that we're seeing at the moment are most definitely moving to the proactive bit. And when we start talking about the EDI strategy, for instance, really good example to say having something that is written, having something with a series of commitments is one thing, but then delivering, deploying and enacting that is completely different. And so one of the things that we wanted to do there is demonstrate with people like the Racing Health Observatory that we really mean it. And I know that sounds slightly flippant, but it's really easy for organisations to settle into a document that then they look at month 6 or month 7 and think, oh, there's a lot of time that's gone on. We're not in that space now. So the 2-year delivery plan that we're in, I think I'm really pleased to say, has got a lot more traction. And all of that strategic framework, and looking at Stephen for a second, we're dovetailing in with the NHS plan, which is really important. But when we do land our new trust strategy, it will be partially through our 2-year delivery plan, but we're not waiting for that. And that's really important. So we're on to this first bit at the moment. Sorry, Chair.
No, all good. Brian.
I was really just picking up on Kish's theme about agency, bank and agency reporting. I note your comments, Steve, about the detail doesn't go through to the people in the culture committee. But I do think that given this is a very high profile target across all of NHS, I think probably we need to just up the reporting for a period just to see how we're doing and just to track that. And if it's fine, we can always reduce it in due course. But I just think that being so high profile, I think it's incumbent on all of us just to know where we are.
I totally agree, Brian. It will go through, as Steve mentioned earlier, we're going to go through to our trust efficiency program in detail, and then it will actually come up through me as well. So actually, there'll be a number of routes that it will be coming out.
I think what I would say is, and I'm sure you know this already, it's just really important to hone in on the sticky spots where you've got persistent need and long-term need. And that's when we get into the, can we do it differently? we sort of break ourselves out of a model of dependence on an agency in particular. All right, Stephen, with you.
Thank you very much, Chair. So just got sort of a few points just to draw out, but I'll just take the reports read. First of all, I think it'd be remiss of me not to mention potential further industrial action. We heard last week around the potential pay rises, increases for medical and dental staff and agenda for change staff and BSM staff. We know that the BMA, prior to that announcement, is going out to ballot its members. And we are hearing that there is some concern certainly around certain particular professional groups around the offer. So we'll be watching that very carefully and also reporting up to P&C committee. Just to celebrate that staff induction has moved back to face, which I think is really, really positive. And obviously board members and exec members are invited to attend to make it much more of a sort of a whole trust event. And I'm seeing some communication around that. Positively just show a slight reduction in sickness, though we are seeing a seasonal trend at the moment. So again, there's further work around that, and we talked very briefly in the P&C committee around a bit more of a deep dive around sickness and broader cases as well, and that will be coming back to the next P&C committee. And then finally, built on your earlier point, Eileen, just to talk about the turnover rate. We are seeing a reduction in the turnover rate over the last 3 months for the organisation, especially around adult OPAC and corporate, less so around children's directorate, and the organisation is currently undertaking the People Promise Exemplar programme. That money ends in June, and we will need to take a hard-on look at whether we continue with that sort of post going forwards. I'm going to stop there and
Any questions for Stephen? Mike?
Yeah, so it's a rather specific point. One of the things we look at policy and safety is incidents relating to inappropriate sexual behaviour. And I just wondered if, we didn't talk about it at the committee last time, but you do talk about a project of sexual misconduct and sexual safety charter. I just wonder if there's, I gather this is in line with the Worker Protection Amendment to the Equality Act. Is there anything to report about that and the impact it might have on incidents with regards to training of staff?
our view at the moment is, because that's work in progress, Mike, is that it may well draw out further reporting that perhaps wasn't there. There is a very clear definition now as well since the October Act. So again, you may find that your reporting is increased as people become more aware, and that's a charter that the organisation has sort of signed up to. We did do a presentation on it at P&C about 3 or 4 meetings ago, and we have said we'll come back as well with a bit more impact on that. I cannot remember in the cycle of business though when we said we'd come back.
Very helpful, because data is important, and if the data goes up, it doesn't necessarily mean that the number of incidents have gone up. So interpretation of data in light of that.
But sorry, but the impact of the Act may also drive some interesting behaviour response that may result in the increased data. So it's something that's currently sort of evolving and emerging, given that.
Yeah, thank you.
Okay, any other questions? All right, I think it's a really rich data set. We are an entirely people reliant organisation, people serving people. So I think it's well advised to dig into some of this stuff, and all execs in particular to really engage with what it's telling us, because these are all collectively our staff. It's not just sits in Stephen's directorate. Let me go then to you, Steve, to talk about the Freedom to Speak Up report.
Thank you.
Thank you.
Again, colleagues will take this as read, but with 2 highlight points, if I may. The first is the implementation of the Freedom to Speak Up case management system. This is directly in response to feedback that we received from some of our external partners, such as CQC, in terms of the responsiveness around freedom to speak up issues when people raise concerns. Colleagues around the board will be aware that sometimes those concerns can be raised on procedural transactional issues or personal issues between individuals or relational issues. If those things are relational, then obviously they need to be investigated. Well, they're transactional, they need to be investigated. That often is the case. Some of those require a little bit of time to really unpack where this issue has been, where the genesis of the issue is. So the case management system will allow us to demonstrate a double loop feedback to those individuals that have raised concerns. Just because there is no correspondence for a period of time doesn't mean that nothing's happening. And that's really important. And we'll be able to play that into some of our response to our CQC questions that were asked around this, as they were asked as a theme around the country, I have to say. The second thing under item 3 of the report, the keen-eyed amongst you will notice the statistical shift in 24-25, over a 65% increase in freedom to speak up issues. I'm actually really delighted that staff felt able to do so. And although this sounds like it's a big increase, actually it's really positive that staff collectively in the services felt that they were able to come to the Freedom to Speak Up Guardians and raise concerns, all of which have been acted upon. And obviously now we'll start to settle back down again in terms of the remedy that's been applied to those. So although that did signal an increase, Mike, your point about data is really important. The context here is super important. Really good that staff can speak up in this respect. For all staff members, though, under Freedom to Speak Up, we also want to encourage as much as possible for staff to raise concerns directly with their line management and with each other, because it's a culture of an organisation. We want to be able to stop the line way before it gets to a point where it's been escalated. And obviously it's there for anonymous raising of concerns, and rightly so, but we wish to see a culture that's much more open and transparent wherever we can. So we'll continue to reinforce that message. Happy to take any questions, Chair.
And let me just endorse your views that people speaking up, ideally feeling free to speak up in their line management, but having an avenue to speak up, and very few of them doing so anonymously. So feeling that confidence of human-to-human interaction is something to be positive about. We'd love to have an organisation where nobody had a concern, but I think that's probably unlikely in the world to exist, a place where everybody feels that things are perfect. But the more people can talk to each other and raise issues, the better for both them, the service, and the people that we serve. But any questions or observations at all on freedom to speak up? Stephen?
I suppose for me, there is a really important little vignette in there, given what the NHS is currently going through and things around service redesign and challenges. And this is not just for CPFT, this is across the NHS. For me, it just reinforces the importance of getting service redesign right, being very inclusive, listening to the whole team, listening to our patients, staff, etc. So I think it's a bit of salutary lesson within the report.
Yeah.
And Pri, I know you're closely involved with this. Is there anything you'd want to add?
No, I think we've covered it all. I think, just to reiterate, it's important that it exists, and it would be lovely if it were never needed, but it's important that it's there, that we have an avenue. And yeah, I think anything we can do to encourage trust in that and that people speak up within their line, or to freedom to speak up, is all positive. But I think that's it. Thank you.
All right, thank you so much. All right, in which case we'll then move to the Business and Performance Committee report. Steve.
Thank you. So the Business and Performance Committee met on the 23rd of April. As with others will take the report as read. I'll just like a few points to highlight. So the operational risk report included 6 new risks. BNP, one or two I think have been referenced already in other committee reports. They include areas around cyber security. We're looking to the Digital Transformation Board to pick up before we get to our next BNP meeting in June, and also the progress against net zero targets. Again, an important risk that we'd like to see addressed, and the Green Plan update, which I think is scheduled for July to NHSE, will play into the timelines for that. But we agreed with those 6 risks should be added to our operational risk report. The finance report, I won't say too much about, Kish will cover it, I'm sure, but the committee was wanting to thank all staff, but particularly the finance team, for the progress that was made to get a positive year-end position. And it's important that that was a really good outcome and important that we recognise that success. On freedom of information, there was a big uptick in the number of FOIs that came in towards the end of last quarter of last year, which I think colleagues are looking at the resource implications of how to manage those. The number responded to within 20 days, 71% was an increase on the years before, but I think still room for that to improve as we go forward. That's the priority that's being looked at. We looked at the literature reduction programme, the investments over the last 3 years that have been made, with 1 or 2 still to complete, but some sort of progress on that. We've spoken about the Trust Efficiency Board, which was mentioned a little bit earlier, and as ever with the agenda, there are items that we spoke about at BNP that are on this agenda. So the operational performance report, operational planning, which will be picked up very shortly, I'm sure. The final point is I think in all items we gave a reasonable assurance, which I think is positive. The one area that wasn't was the service visit reports, which was reasonable in terms of the quality of the report that we received, but partial in terms of the follow-up and some of the actions in there. And I know exec colleagues are looking to address those actions, and probably are already doing that as we speak, in time for our update next time in June. So I'll leave it there. Thank you, Chair.
Thank you so much, Steve. Steve.
Thank you, Chair. Thanks, Steve. Just on the report on page 3, just under information governance and freedom of information, what I think I'm starting to see a lot of is a heightened increase in the number of FOIs that we're starting to see, but complexity of them as well. And when you I sign a lot of them off. They're written by AI. And so when you start to unpack them, cybersecurity at the moment is on our vulnerabilities from an infrastructure perspective and so on. What I don't think we've been able to do yet is take a step back and ask ourselves, how are we able to respond to what is a significant increase in AI-generated freedom of information? Because some of it is overly legalized and very complicated, which takes a lot more time to unpack because you're never sure as whether it is being generated by a bot or some form of automated process or an individual using AI, which is going to be something that we'll need to do a review over because our targets for return may be affected by that. As I just see some of them are so complex. Just a point to know.
Yeah.
I'm going to Mike and then to Brian.
Yes, so you refer in your report the changes to the learning disability ABU, and this came up at the Quality Committee as well. And I just wondered if it would be worth just saying something about assurance of stability of the service whilst we look at the opportunities to review the Learning Disability Partnership. Is that fair to ask that? Yeah, thank you.
Yeah, do you want to respond now?
I can do, yes. So colleagues will be aware that obviously Learning Disability Partnership has dissolved. So the ICB are taking for commissioning the health component of that care. The local authorities are taking responsibility for commissioning the social care aspects, whereas before it was a pooled budget. So actually it's been very complex to unpick in terms of really identifying where the finances go and then making sure that we've got resources in the right place. Where we have landed is that we've got an agreement that for the next year we will offer an as-is service. So actually from a service user and carer and sort of support perspective, they shouldn't see any changes. What we have committed to though is starting in June a transformation of model of care, particularly focused around the health elements, because we know that actually they're operating a model of care that hasn't necessarily kept up with national best practice, and obviously that's what we want to provide. So the ICB will be responsible for leading the transformation because it will then lead to a recommissioning of that service. But currently
for service use.
Stable at the moment, but we'll watch and see how,
Yeah.
and from my point of view, it's the quality of care that
Yeah.
patients receive.
I'm going to Brian and I'm going to Kish, and then we'll.
Mine's follow up on the AI point on the information requests. There are tools available to test whether something has been written or delivered by AI, and I wonder whether it's worth the digital committee having a look at those just to be able to identify those. Yes, and it's the second point really that comes off the back of that is that to the extent that it's a bot which is creating something, if you reply, is there a mechanism by which you can reply with an intermediate, oh, can you tell me what you really mean by paragraph 2 or something, which would allow you to really tease out whether they are real requests or not. Because again, what we don't want to do is find ourselves in a position where we're spending lots of time answering irrelevant points, but by the same token, it's important that we do obviously address all the requests that are being taken on board. The use of AI is it's become a sort of like a cheap solicitor for lots of people almost, that they're using it to ask questions they otherwise wouldn't have even known how to ask, and this is going to get more complicated, not less.
Yes.
Indeed, technology, progress, that's the exam question, and the interesting challenge for the law as well as to how the law would treat a request that was made entirely via AI. Kish, and then we must move on.
Yeah, I think my comment is actually about BLD and what stability means. So invariably, when you pick a service like this, and you get to know what the numbers mean, okay, the service may not be fully funded, and we will have to provide a reaction to that to come back to what is actually means.
I mean, in terms of this, I know that everybody touching this will have front of mind that if you're an individual, a family, a carer, you don't want organisations to be doing anything other than focusing on how to give you a consistently good service. And that's our duty really, is to speak to that. I think Fish is quite right that when we actually start uncovering things, we'll notice that some areas of funding have not kept pace with what we've actually been delivering. All righty, then can we move, Holly, to your report?
Yeah, thank you, Chair. I'll take the report as read, and obviously and some reference elements because the report goes through business and performance and quality, safety and patient experience committee. But just to highlight a couple of areas, we are reinvigorating our out of area placement work programme. I think we've seen an increase actually in both appropriate and inappropriate. And so that is now going to focus on how do we get the best use out of the capacity that we've got, and looking at making sure that we're using the bed stock appropriately and reducing length of stay. We actually only have to reduce our length of stay across our inpatient areas by 15%. To sort of eliminate our inappropriate out of area placements, which seems entirely doable. And I think looking at it with that lens is helping with the engagement of some of our clinical colleagues, because it sometimes feels as if it's a really big problem, but actually trying to sort of say this isn't about sort of massive improvements, but small incremental improvements will really make a difference. But obviously it's a huge focus, both from a patient experience perspective, but also the on our financial position. We've spoken about concerns around waiting lists, and so we have put a new risk on the back that actually aligns to the fact that we are seeing increasing capacity and demand, but obviously again because of the sort of NHS context in terms of finances, we're unlikely to get significant increases in funding for those services. So actually it will be around looking at how we can transform delivery and make sure that actually we are addressing those most in need, but also being really effective and efficient. And then just to highlight that we have slightly changed the format of our performance and risk executive meetings. So those are the meetings that we have with the directorates on a monthly basis, and it's how as executives we get our assurance, but also how the directorates can engage with us to ask for support. And we've introduced a sort of more focused process looking at the alert, advise and assure structure. So we've had our first round of meetings and actually have had really positive feedback, both from the directorates, but also from executive colleagues, feeling that it's a more focused conversation. We've also managed to shorten the meetings by half an hour, so giving back a bit of time. But happy to
Just a very brief one, Chair. Kathy, this is exactly where the clinical strategy plays in. When Holly is talking about operational challenges around things like waiting lists, one of the things that we have to be able to be clear about is we can only transform so much out if the demand is outstripping the capacity that we currently have commissioned. So this is not a cheap shot to say we need to recommission stuff, we need to do more of. This is an opportunity to say the forecast of the demand has to be really clear within an equality and an equity model that is attached to it over the period of time, so that we can see demand changes within the population, because there will be a tipping point where we can't transform anymore just because the demand is outstripping the capacity. So it's just a really good plug to demonstrate how this links into all the rest of what we're doing. And then that will form part of our service specification review when we look at rebasing some of the activity within the contracts.
And I think having our public health colleagues supporting the clinical strategy is really helpful in this respect, particularly with the mental health needs assessment, but also the data around physical health services.
I mean, it is probably worth drawing out. I'll come to Steve and then Mike. On autism and ADHD, the issue is a national one, children and adults, of exponential growth in referrals for potential diagnosis and then possible treatment if there is a positive diagnosis. I was in a meeting with chairs of many trusts who are experiencing the same issues as us. I was not massively reassured by representative of NHS England and the department by who I'd understood were developing a national strategy around this. I think it was true to say that they were putting forward a view that it was not well developed. So solutions are going to have to be sought, I think, by the people who are trying to manage the demand, and it is going to require a huge leap of imagination to think about how we can do better to get some level of service to people who are facing very long waits. Let me go to Mike and Steve.
Okay. Yeah. It was really just to ask about DNAs, did not attends, and there's quite a high percentage of DNAs in the adult specialist mental health, 30% actually. And it's an interpretation of data moment, really. Is this a good thing or a bad thing? Obviously, it's a bad thing that people don't turn up, but as I understand it, we're keeping patients who might otherwise be lost to follow-up on our books by keeping them reporting on that data.
obviously from an effectiveness and efficiency perspective, we would want to sort of have as few DNAs as possible. It means that we can see more people. Quite uniquely in mental health. So if you were on a sort of physical health waiting list or in an acute, you would have a sort of 3 opportunities and then out. So if you DNA'd 3 times, you would be written to and told that you were being removed from the waiting list and your GP would be informed. Obviously for mental health patients, we don't do that because we recognise that actually there is a sort of myriad of reasons about why people can't attend or are unable to attend. And I suppose this is where potentially some of the assertive and outreach work will support, because actually quite a few of the patients who don't attend will be in our serious mentally ill cohort of patients that actually just find it really difficult to engage in a more traditional way. So having that team thinking about different ways potentially will have a positive impact in reducing that DNA number.
Yeah, just wanted to pick up on the, I think done before, delayed discharges and the work with wider ICB colleagues to try and help us with that. I just wonder if we are making any progress on things like housing.
it's a yes and no. So actually, I think we're in a position where we've got good engagement with the local authorities, which isn't the position that we were in probably sort of 6 months ago. So we have a regular meeting set up both north and south to discuss all of our clinically ready to discharge patients. The housing remains an issue, particularly sort of a certain level of supported housing. Both Cambridge County Council and Peterborough have been very open and honest around what they've got available, and there isn't enough for demand. So they are looking at actually what are alternatives to try and support that. But housing remains a real issue around capacity, whereas before I think it was both capacity and lack of engagement. I think we've solved the engagement, but there isn't enough of that particular provision.
I can go back to my sustainability question. Some brilliant work went on around out of area placements, both appropriate and inappropriate, to drive numbers down. We're now seeing an increase. We've got to both get them down and be able to sustain without having to keep cranking things up to really turn the tap off. So I think the board will want to be very interested in how that is progressing. But you know, I will keep saying that some of the things called appropriate are still really hard for people. That should be kept much closer to home. And we'll keep that as a board. All right. Can I move to you for the finance report?
I think the paper is read. First thing I'd probably need to say is that the numbers are based on the unaudited accounts. So they are the year end 24-25, but unaudited. We'll receive the full audited accounts next month. The first thing to say is that the income and expenditure position shows that we achieved our target, slight surplus at 32. Compared to the 4.7 million deficit we were showing in the last quarter, more or less consistently. And that's a testimony both to the organisation's effort, focus, and also system working together as well to make sure that we got there. That said, I do need to point out that the underlying position of the organisation includes £6.1 million worth of support from the ICB, as well as a number of non-recurrent measures which add another 7 million. So the underlying position is quite significant that we face in 25-26. Within the income and expenditure position is a more than reasonable achievement of CIP at 3.8%. Okay, it wasn't the full amount that we wanted at 18.1, but 3.8% is not exactly an insignificant sum either. Cash flow remains strong in the organisation. We're one of the handful of organisations still left with significant cash balances. So that assists the organisation in its planning and also ensuring that there is appropriate regulatory oversight for what we can do and what we can't do. Just turning to the capital plan, you'll note that overall we are underspent on this, okay, quite significantly so. And some part is a reflection of the fact that we over-programmed the capital plan to begin with. We also, has to be said, did underspend against the plan that we did have. That probably leads us to some learning points, both for the cost improvement programme and the capital plan going forward for next year, which is to be far more specific around what we're going to do when, and to rely on assurances based on plans as opposed to things that we're hoping for but might get in the way because other people aren't able to get resources in or we're dependent on other people doing things. I'll broadly conclude there.
All right, thank you so much, Kish. Question for there's nobody in any doubt that the challenge, the requirement to break even is not an insignificant one. It's where we started the meeting. It's where we will keep coming back to, but we've got a duty to do it. Non-negotiable that we have to achieve during the year.
Just one comment really rather than a question on the capital plan for 25-26. We appreciate the rigour that Kish has spoken about, noting that the outturn from last year, the biggest spend in line was other states, which is vague, but obviously important. If we can categorise more directly in 25, 26, which we will do, then I think that's the bit very helpful.
Thank you. I don't, Steve, that's a really good point, and I think this is Kish's point around, but perhaps, pardon my phrase, but having more oversight and a bit more discipline in terms of what is scheduled and therefore what is agreed as priority. We are ultimately going to face difficult decisions of what priority means, because everything's urgent, everything's a priority, but there is a phasing that we can do with the right level of sophistication, and I think that's always going to be a challenge. The other thing we mustn't lose sight of is this is our capital plan, but there is an opportunity as the year continues, potentially for capital funding to become available for specific innovative approaches, particularly things like repatriation, investor save concepts and so on. And National are really keen to see that. So when those opportunities do arise, as an organisation, we need to be able to be responsive against that. And again, I'll use the word sophisticated in how we apply that. So not just throw ourselves at everything, but to be really clear about that. We focused what's in our clinical strategy is where our priorities sit first, and where our transformation agenda sits around that, as well as our backlog, as well as some of our issues to do with the therapeutic aspects of the estate. And colleagues can be assured that that never loses attention, because we often focus on the clinical interventions, but the therapeutic environment that we operate in is equally as important. Hence, really an unrelenting focus on ensuring that that is safe and to the standard that we would expect to be if we were in an inpatient service ourselves. We do have some challenges with some of our partners who are facing some capital challenges, shall we say, with regarding buildings that they own that we occupy. We are sympathetic to that. However, we need to be really clear. We still have a duty to the workforce that is within those buildings and the patients that we see. So although we are sympathetic to that, we can't accept substandard accommodation for those members of staff. So again, we'll continue to work that through, feed all of that through business and performance.
Just add one comment, a bit like how I described the earlier part of the meeting, quality and performance drives the money. The plan in the same way needs to be driven by the service to be able to get the quality and the performance. There's no point in there's not going to be driving an action plan. I wouldn't be able to make the right decision.
Well, I know that you and Steve have got some good ideas to get staff to be very active in telling us about where we need to make capital improvements. So that I think is brilliant, and as it should be. Certainly when we do service visits, there is never a shortage of people drawn to our attention where some of the buildings that they're in, Steve says, many of them we don't own, but where we should be being very assertive about what a reasonable working environment is like. All right, Ish, I think great. Thank you to you and the team for the work you're doing. We are going to need to be really assured now, month by month, that we are seeing the savings that we need to get through this year. And always remembering that quality of care is the absolute priority for what we do. But actually, poor quality care is usually much more expensive in terms of impact and outcomes than high quality care. So if we can bear that in mind for everybody, then the money and the care elements come together in a rather virtuous way. Stephen, can we go to you then, the operational plan?
Thank you very much, Chair. So I'm really conscious that we've already done a number of sessions with board and obviously with the Council of Governors. And, our directorate plans have been sort of built bottom up through the directorates, but we felt it was important to bring a high level summary to public to make sure it was put in the public space. You've got a set of slides and I'll quickly just run through those. The first slide talks around sort of the planning process for 25-26, begins to talk about, some of the narrative around triangulation between finance, performance, workforce plans, etc. And begins to talk a little bit around some of the ask of us from the centre around sort of corporate administration reduction as well. The second slide then begins to talk about sort of the alignment of our plan to both internal and external programmes. Talks about, very much the directorate plans, and we have those very much sort of driving there, and we need to monitor certain elements of that through the PRE, etc. And obviously we'll talk a bit more around efficiencies in a moment, and sort of the overarching plan for the organisation. And as I say, that's been built up through the directorate plans. And then obviously we talked about earlier on around the 15 big moves for the system. So we need to ensure that our plan aligns to those big moves as well. And again, we'll talk in a second around the trust-wide initiatives that are being built up, as I say, bottom up from our sort of directorate and corporate plans. Next slide just gives you a bit of the operational timeline. I'm not going to go through that, but you can see we started much earlier in sort of October. Nationally, the guidance came out in late January, early February, and there was a significant push. And again, we probably need to thank the organisation for putting together in order for not only our plan, but actually supporting the development of the system plan as well. The next set of slides then basically begin to just pull together the priorities. And we've already started talking about some of those priorities in the board today. So, for example, we're already talking earlier on around PCREF. We're also talking earlier on around increasing flow, reducing delayed discharges. We've already had a bit of a conversation around ADHD and autism, etc. So again, the sort of the focus for 25-26 is already sort of flowing into the board and the board narrative and the conversations that we're having. Again, we've got down there around maintaining financial control, and you can see sort of the efficiency program as well. And in our plan, we've got certainly a section on sort of enabling innovation and research and sort of growing our research and our commercial trial portfolio as well, which we think is really positive. We've already spoken earlier on around the community mental health baseline review. It's a piece of work that we started with the ICB this week. We're going to have a discussion at exec this afternoon in a bit more detail around taking that forwards, and obviously being the lead for that piece of work. And then on the next slide, you've just got a bit more details around the quality agenda, people and culture agenda, and research agenda. And then finally, our plan talks around how are we going to sort of make sure we've got the right governance to ensure we're delivering. And again, we've already begun to talk about, having the efficiency program board, having an overarching sort of feed up to business and performance, and trust board. And again, we've already heard from Mike to make sure that, quality impact assessments are done as part of this, and the quality impact assessments are done as part of this that go through to the People and Culture Committee as well. So that's a very quick run through of 6 months worth of quite detailed work.
Any questions or observations, Steve?
Thank you. I think this is an excellent piece of work, Chair. And again, this is against the backdrop of this year's current priorities. This will form part of our 2-year delivery plan, which Stephen's already mentioned. There are 10 priorities on slide 5, which are really important that the board will be cited on, that we've talked a little bit about. But just want to mention one, if I may, just a shameless plug. When we start talking about expanding care outside of hospital settings. When you talk about virtual wards, you often talk about the acute sector and supporting people in the community, waiting for surgery or waiting for some form of intervention. I just want to hand back over to Kathy, if I may, for a second, because we should be really proud of the fact that we have broken ground here with one of our clinicians driving innovation with an acute partner, looking after some of the most vulnerable people that we have in the communities using virtual wards from a mental health perspective. That is a drum roll moment for CPFT, but can I just roll the drum and ask the Chief Medical Officer to give a quick update?
Yes, absolutely happy to do that. So one of our consultants in Peterborough, who has some academic sessions, has been using those to develop a project. It's a pilot project around the initiation of clozapine, which is a drug that people are prescribed when they have treatment-resistant schizophrenia or very severe schizophrenia. And normally, in order to initiate clozapine, you have to admit someone to hospital because you need blood tests done and very close physical monitoring. Those blood tests and the physical monitoring can be done via the virtual ward and the person checked regularly. So we've just started that pilot and have successfully got the first patient through. So it's cost saving, it improves patient experience because they avoid admission, and it helps with patient outcomes. So it's a win-win. And we hear now that others are beginning to think about it. So it's good to be on
the record to be the first.
Let's put that on record.
Yeah, that's excellent.
And of course that addresses health inequalities as well. So because it's Peterborough based and we traditionally had difficulty.
Well, interestingly, it's come from a health inequality in that we had a service in the south, but thought, what can we do in the north in order to equal things out? And so in the north now, we've got the very innovative service. So hopefully we'll bring that down south.
Excellent. That is what we like to hear. All right.
So thank you for drawing that out, Steve. Thank you, Stephen, for the hard work and everybody who contributed there. Again, absolutely key to keeping us tasked for the year ahead, the now 10 months ahead, to make sure that we drive up quality and bring the money in. Can I go to Mike? I think you're going to give the Head to Toe Charity Committee report in Jackie's absence.
Yeah, so we met Hannah earlier, Hannah Mazoki, who led that presentation on the Butterfly project. So we should call out thanks to her for everything. It's a small charity with a small team that carries quite a burden of the work and the successes. Also, thanks to Ed Fulmore, who has been co-chair, and you've already alluded to the fact that he's stepping down as a non-exec. I think 3 other points. We've changed the name of the committee to be the Head to Toe. In terms of this board, we've changed the name of the subcommittee to reflect the fact that that committee doesn't just look at the money, but it looks at the impact that the charity is having, fundraising opportunities, and engagement with potential funders. That includes work on rebranding the charity as well. So internally and externally, it'll have a different face, different personality. And lastly, Chris and others have been working on the sustainability of the charity over the next few years. And one of the components of that, which I think is really important, is looking to increase our general unrestricted funds, which gives us opportunities to make bigger grants to CPFT and give grants to those areas of the organisation we think are important, but perhaps people don't give money for. It gives us great freedom to invest the charitable philanthropic support we get in different ways. So that's the sort of themes that have been emerging from my agenda to the.
And yes, again, to note, thanks to Hannah and the team, as beautifully displayed by the Butterfly Service presentation we had this morning, and great to see it renamed, probably reflects the conversations that happen. But any thoughts or questions? All right, in which case, Brian, the floor is yours on audit and assurance.
So we had another insurance meeting last month. It's a quiet month, relatively, because we don't have any major documents coming to us, and we're not quite ready to sign off at that stage. One of the key things is that obviously the timetables this year across either reporting have been rather tighter than ever. We did get the first set of numbers about the 28th, which is good news. That's, Chris, I'm looking at you because you're running the big project for the full document, which I understand was on schedule.
Yeah, on schedule. Went to auditors on the 28th, and we're now working through the findings from that audit and just basically making sure it's ready to be presented at the Audit and Assurance Committee by sign off.
So that's really good news. And actually, I mean, compliments to you and your team as well, because that's been a slog in years gone by and hasn't always been on time. So I think that's been progress, which we should properly recognise. I think in terms of the external audit work that's being done, there's a more detailed scope that's been applied this year as a result of some matters that have been raised or identified by the external auditors, which I think has given Kish's team a bit of a problem in terms of the size of some of the samples that have been asked for. But I think you're plodding through is the short answer. So that's something that is inevitable, happens from time to time.
It's the right thing to do.
That's the right thing to do, exactly. Internal audit progress report. It's ironic that at the time consultant job planning was a big problem, and guess what? Even Kathy's got to 95%, which is fantastic news. Which and you know, the thing with internal audit is sometimes it comes to problems after they've already been identified, and I think in this case they did, and it's great news that that's being resolved. Some issues were raised around rostering. We're no worse than anyone else, but some action still outstanding on that. As far as internal audit opinion is concerned, the internal audit partner has to sign off an opinion for us. It's expected to be the same as last year, which is kind of amber red, so it's not green, which is what we'd obviously like. But I think that I was reassured that Liz, the partner, was at pains to point out that report controls aren't necessarily declining, but you probably have 2 years in Perda before you can improve. So So I think we're hopefully in the right path into next year again. There was no additional cause for concern that hadn't been flagged anywhere else. Many other meetings that we've had. Some progress in internal outstanding inspections. That's one of the tests of whether the organisation really is taking their response to internal audit seriously. There are a number of actions, too many actions probably outstanding and related. So I think Elaine Bailey was going to be tasked with looking at the people ones in particular, because I think that's where the bulk sat. So we'll pick up on that later on. And other than that, it was sort of as usual, really nothing else in detail to report.
Thank you, Brian. Any questions at all, Brian? I mean, just to note, if audit actions are outstanding for a long time, I think I would chair. I'd be expecting an explanation as to why. So do feel free to escalate.
We do have a process of inviting people to explain why they haven't been answered. So that seems to make sense. Yeah,
I'm sure Steve would say it should not to be so. So I'll leave it in your capable hands.
Drop me a note first. I think it was probably the politest way of doing it.
More chance to get them. You're allowed to be overdue once. Overdue twice.
Yeah.
What kind than I am, Brian? All right. Thank you for that. And as you said, pace is now going to pick up in that area. Steve, can we go to the Children's Hospital Committee report?
Okay, so the Children's Hospital Committee met on the 7th of May. And the report summarises the items that we discussed. So the work on the full business case for the hospital is progressing to a submission expected in April next year. A number of strands of work within that, as you'd expect. What we've just covered in the paper is those that are key for us in the next 6 months as a project. So an appointment to the pre-construction services contract should be made soon, in the next few weeks. That is an important step, and that to some extent will define the work plan going forward. Also, a decision that will be brought forward is around the joint venture arrangements for the design, build and operation. And again, that will be something that will come back to this board for a decision in the early autumn, having gone through various committees. In the lead up to that, work is continuing across the partnership on fundraising and also in recognising how the project contributes to government priorities across different departments, so that we're hitting the right notes when it comes to putting the case forward for funding. And that funding package will become clearer what's needed as we appoint the pre-construction partner for the project. From a CPFT perspective, we will be providing an update on where we are with the Iford Darwin site, which is an important issue for us. And that has to be, work is continuing, and I know discussions with Homes England are continuing, and that we'll keep a very close track of that. But we do need to provide an update to the Joint Investment Committee in government in July. So it's important that we are able to make progress in those discussions with Homes England that are positive, and the work is carrying on with that right now. And I think just to remind ourselves that some key decisions that I've mentioned will need to be taken by our committee and this board in order for the project to progress. And I mentioned a couple of those already, and ultimately the full business case early next year will need to be signed off. And those key decisions are in the forward look on the final page of the report and listed as dates. And we're keeping that very much under review to guide the work of the committee, but also to keep the board aware of decisions that are coming through and when they're due to come through. So that is an update, Chair, from Children's.
Thank you. Kish.
To reinforce what Steve said on the last page, there are some key decisions that will be coming to the board. The two immediate ones will be, one is the SPV. Okay, that will be coming to the board in July-ish. Okay, there is a board seminar that is being requested. Okay, so anybody can ask more detailed questions. And then Finally, in September, there'll be a formal request to the board to sign up on the SPV being created.
I think, as we've said before, this is going to merit very serious consideration. The Children's Hospital combining physical and mental health services is a fantastic project for the East of England. So it's incumbent on this board to make sure that we are as thoughtful as history would want us to be around all and every undertaking that we make around this. So we are going to have to keep coming back at it and be very mindful of decisions that we take and commitments that we make. They are absolutely in the best interests of our children, young people and their families, both now and for the future. So thank you for that. Thank you, Steve. Any other questions on Cambridge Children's? Mike?
Well, it's an observation really that, to my mind, when you're building a new hospital, that is just a building. It's what goes on in the building that matters. And I'm pleased to see that there's a front runner programme which is looking at ways in which services can change now before you build the building, and whether the building happens or not, which we hope it does. Transformation can take place now in terms of integrating services. I don't know if that's a fair observation, but it just seems to me very helpful to see changes in the way in which we're working together across physical and mental health in advance of it. So the front runners programme is something I'm kind of interested in seeing how that develops.
Yes, so I think that's a very good point, Mike. And a nice example of that is one of our clinical academics who is a child psychiatrist, and her area of expertise is around application of the Mental Health Act in children and young people, is looking at how to support the acute trust in reducing restrictive practices, and when there is a need for mental health trust, how to apply that correctly and to improve the care of those children and young people in the acute setting. So there are things that are happening now. And the idea of the Front Runners programme is we're really like a living laboratory for innovation. And that's something that we will continue on into the hospital once it's built.
We are a living laboratory, full stop. Excellent. All right. If we could move on then, to note that the trust seal has not been used. So thank you, Nikki, for having confirmed that. Steve, with you for a report on the High Performing Organisation Programme.
Thank you, Chair. So again, the report will take us thread with a couple of points to highlight. So I'll keep repeating myself. We entered a 3-phase programme last year, one of which was from October through to April, which was our 6-month recovery agenda. Kish has talked about that. From a financial point of view, we had a range of operational challenges that we wanted to address, as well as governance issues that we wanted to strengthen. So that was in that 6-month programme. The next period from April onwards was our 2-year delivery plan, which Stephen's mentioned in terms of our operational plan leading into the next 2 years, where we'll talk about transformation and sustainability of an organisation as we move through this, and then not losing sight of the 5-year agenda, which is more of our strategic intent, of which you will hear a lot more coming through the clinical strategy around not just responding to the immediacy of need, but talking about prevention, talking about inequality, and then talking about the future. Looking back to where we are now, so 47 actions completed up until the point of April, which out of 47 is a good sign. You'll note on page 3, the octagon. I don't know whether that's a good word, but you'll notice the diagram at the bottom of page 3 of the 8 key areas which we were able to reflect with our CQC partners as to the new 2-year delivery plan of the Trust, which did land well and took resonance with them. We also went through a well-led review. We had a review of our independent auditors, RSM, that did a review. This is in relation to our effectiveness and efficiency through meeting structures. We then had Grant Thornton come and do a review over our governance arrangements, some of our decision making, which was incredibly helpful. We've aligned this piece of work now to a document called the Insightful Board. If you've not seen that, I would recommend that you do look at that. That is part of our new framework moving forward. We are then looking at a redesign of our PMO functions, so our PMO services, so project management office, program management office, so that this board gets much more visibility over our business critical issues, not our risks, but our business critical pieces of work that we want to work through, which will be directly aligned to our efficiency agenda and quality agenda. We are applying a second layer of discipline to that, which is a program office set of disciplines, which the first cut of that, including our efficiency agenda, will go through business and performance at the next meeting. And there's been an already significant amount of work on that, which I'm hoping colleagues will be assured by. The next piece really is to talk about how we then want to use the programme to align all of our sub-strategies as an organisation. And again, sorry to be a little bit indulgent from a strategic point of view, Chair. When we look back in terms of the number of strategies that organisations often have, they can be in the sort of double numbers. So they could be an EDI strategy, it could be a workforce strategy, it could be a financial strategy, quality strategy, and the list starts to go on. In order for good organisations to have oversight of this, then those things have to align. They have to be jigsaw pieces that connect to each other, to enable each other, and they don't bump into each other. So we've created a portfolio board which will bring all of those strategies together so that we'll then be able to present to this board much more of an aligned architecture in terms of what we're doing against all of our corporate, clinical, and other areas in terms of our strategic direction. The final piece, which is really important, is that we will evolve the HPOP programme, which this paper refers to, into that now with the new portfolio board starting at the end of this month. That will give particularly executives and directors direct line of sight over the transactional delivery that we're talking about, month-on-month updates that will come through to the board committees, and much more assurance and deep dive to enable us to identify barriers and unblock those as quickly as possible. The most important thing about this is that we mustn't be prosaic at this phase in our strategic development. What I mean by that is if we just focus on our big issues and the world around us changes dramatically, then we will bump into that world as it starts to develop. So we are already aligning the transformation agenda back into this board so that we can see our internal priorities, how we then add to the external priorities, and then how we respond to national and regional issues as they come in. So I'm really pleased to say that we'll start to report out on that, either next board or the board after the next public board, but through the committees of the board so that you get that level of assurance. I'm happy to take any questions, Chair. It's a good piece of work, to be fair.
Well, I think people haven't had a chance to look at the insightful board. It is insightful, but it's also quite clear in terms of what one should be focusing on, what we as a board need to focus on, and I think it's a reference. But any questions at all for Steve? Okay, Steve, always with you again, and I'm sure you want to thank Nikki for this. The annual self-certification provider license.
Thank you, Chair. I'm going to thank Nikki and then hand over to Nikki in that same breath. So Nikki, please.
Thanks, Steve. So as a foundation trust, naturally, we have a licence by which we need to operate, and that licence outlines a number of responsibilities that we have to deliver upon on an annual basis. One of those is around a self-certification process, and that is particularly around continuity of services. This is a specific requirement, and it primarily focuses upon those areas where there are not a plethora of different services available, and such within our local area. We are the sole mental health provider trust, and therefore we have a responsibility to maintain a continuity of our services. We have a self-certification form which is kindly given to us by NHS England that we are required to complete, and this is then available for the oversight framework where we are monitored against our compliance as part of our duties and responsibilities. So this licence and our self-certification comes to the board today. It recognises that we have our contracts in place in order to maintain our services. It recognises our operational plan and our responsibilities to deliver upon those services within that plan. but it also identifies the risks and the challenges that we have around some of our capacity and demand, but that we are working with our commissioners in order to seek to resolve those challenges over the course of the year. So with your agreement, please, Chair and Chief Executive would consider that on behalf of the board and then give your approval, please.
We'd all be delighted to approve. Thank you.
That's great.
Yeah, thank you so much. I know there's a lot of work that goes into that, so thank you so much. Brilliant. Steve, was there anything you wanted to draw out today, or should we move on to questions?
I think just if I may, this is a really exciting moment for CPFT, which is a bit of an AOB, but a significant thank you to the University of Cambridge for recognising the Trust's contribution to research and innovation, and recognising that formally in two ways. One is to approve the organisation's university teaching partner status with the Trust, which also allows us to use the crest of the University of Cambridge and to designate ourselves as such. It is a defining moment for organisations in our sector when you achieve something like this. I don't mean to take away any of the achievements of some of our acute colleagues, but often when hospitals are built, this is baked in. For our sector, it has to be pursued and pursued with significant vigour, of which the team have done so. Dr. Underwood and Kathy have led out on this, and I think there's a significant thank you to the team for the amount of research prowess this Trust has had. Dare I say, and I might get this language wrong, Kathy, so I apologise, research is fantastic, but applied research is even better. Applied research, the ability to influence service change, to make differences, to learn from lessons, to learn from data and others, to improve the care that we give. That's what this is all about. Being able now to talk about that publicly, to stand up with only a small handful of providers and the only provider of our sector with this relationship with the University of Cambridge is quite a proud moment for this Trust. It should start to have a real signal message to those looking for employment, for those looking for advancements of their careers, and also those looking to really help local people to do things differently. A really good stance that we're taking within our system. Kathy, is there anything you want to add?
Well, I wanted to thank you for your role in this because you've been very instrumental. And also to say that research active organisations have better outcomes for patients. It's evidence-based, so really, really important that it's acknowledged in this way.
Indeed. So we are rightly proud, just as we're rightly proud that, as we heard at board not many meetings ago about our Queen's Nursing accreditation, all of these things, we're going to have a very busy backdrop in terms of the things that we're proud of to be associated with. But a huge thanks to our staff because they're what's made it happen, their hard work and expertise, and brilliant for CPFT and those that we serve. And we've got just a very few minutes left. Jonathan, I can see you've got a question in. I'm going to go to governors first to see if there are any questions from our governing from governors with us. If not, Jonathan, I'll invite you to ask your question.
Yes, thanks very much. I've just got one particular question just to raise. It's about patient experience. I'm very pleased to be part of the Trust's Patient and Care Experience Committee. And a month or two ago, we were talking about the National Community Mental Health Service Users Survey. People will be aware of that, I think. It's been around for a long time, administered by the Care Quality Commission, and often seen as a very useful way of actually digging into the patient experience, because you can compare your performance year on year, and you can also compare yourself with all other mental health and community NHS trusts. So it's shines a light on patient experience quite effectively, in my view. And in my professional life, it had quite a high profile in the trust I was working in. And I was just a little bit concerned, I guess, at the meeting I've mentioned, the Patient and Care Experience Committee. I didn't really pick up any great reflection on or interest in what the latest survey results were telling CPFT. I mean, the results came out in April. It didn't really seem to have a great priority, remembering that this is about people's experience, not only working age mental health services, but also older people. So I just wanted to mention it, I guess, for two reasons. It does seem to me that I hope there will be, as you've been saying earlier in the meeting about the importance of not just looking at information, but learning from it. So I hope there will be learning, partly because actually, without going into the detail, the results were not good for CPFT. So I hope there'll be the learning happening now, because the results weren't very good, but secondly, because this is something that happens on an annual basis. So the window of opportunity to actually make things better is very tight. So I think the next survey, letters inviting people to give their views will be something like September. So I'm just mentioning it really with the hope that it will be given the attention it deserves this summer.
Thank you, Jonathan. Well, indeed, thank you for all that you do to support the trust. I'm going to bring in Mike and Rachel.
Yeah, so Jonathan, thank you. It's really helpful. It makes me think, we should give users surveys like this the sort of same attention we give staff surveys, really, because they're the ones who actually benefit from. So you have very helpfully given this a push, not entirely needed though. I mean, it's a push to help us get further on with it, but we did discuss this, and Anna Took brought this to the February Quality and Safety Committee. I hope this gives you some assurance that we are taking it seriously. And we're looking to see an action plan on the back of the latest mental health service user survey. So that in February it was 6 months, so it'll come to the July, or anyway, later in the year, we'll see an action plan on the basis of what that survey found. And then she also reported that each of the 3 directorates are looking at this themselves, so children, older people, and adults. So, for instance, we heard that the adults directorate are focused on developing an audit to support more systematic approach to developing potential challenges around care planning. So that was one of the issues that came out. But your question has helpfully sensitized me to look at this again in some more detail as chair of the Quality, Safety and Patient Involvement Committee. So, but what I can assure you is that we are addressing this, and perhaps it just needs to be given a little bit more visibility.
You're ringing, Rachel.
Yeah, if I'm honest, I think you should follow this up and Tuke and bring it to we've got Quality and Safety Committee, next committee, 18th of June, I think.
Yeah.
We will raise it for a paper there, Jonathan, to find out what progress has been made since the report was published.
But yeah, what you're hearing is it's a really helpful reminder, Jonathan.
Really helpful. I guess what I would want to add, Jonathan, that is of note within and links back to our quality priorities in terms of us implementing Dialogue Plus, and I'm sure that will be coming back to the user care groups for input to that. That's just had a complete refresh in terms of the project plan and is moving at pace now. So I would hope that that's going to be fed back into the user care board as well.
Thanks very much. I mean, just to say, Mike mentions a February meeting, but the last year's results only came out in April. So, yeah. And that's why. And secondly, the Children's Directorate, it's not about children and young people's mental health services. So I don't think they.
I think the issue, Jonathan, is not by way of an excuse, is that the NHS is sort of awash with surveys and information that come in, and we need to make sure that we are talking about the one that you're talking about. So let's take it away, make sure that Rachel and Mike bring it into the next Quality and Safety Committee meeting. Let's follow through, and if you'd like to have a chat outside of this with us, so that we can make sure that we are really following these issues through, I'd be grateful for that.
Thanks very much.
All right, thank you. Any more at all before we move on? All right, in which case, let me say huge thanks to everybody who's joined us online today. Lovely as ever to have you with us, and we'll meet again in a couple of months' time in Public Board. Take care, everybody.
Thank you.
Bye.
Bye.